will be Chapter 7 of Pance Prep Pearls, the endocrine system. So first we'll start with adrenal disorders. And just to recap the anatomy and physiology of the adrenal glands itself, we have the zona glomerulosa, we have the zona fasciculata, and zona reticularis. So the mnemonic is GFR, glomerulosa, fasciculata, and reticularis, and this is the cortex, or the outer area of the adrenal gland. And respectively, each section of the cortex secretes hormones. So the glomerulosa secretes aldosterone, which controls the sodium balance. The fasciculata secretes cortisol, and the reticularis secretes estrogens and androgens. So it's GFR for glomerulosa, fasciculata, and reticularis, and then ACE for aldosterone, cortisol, and estrogens, or androgens as well. Next, the hypothalamic pituitary axis. So the hypothalamus turns on the thermostat, the pituitary gland, which turns on the radiator, the adrenal gland, which produces the heat, such as cortisol or desired temperature. Negative feedback is important to understand. This is when the heat, or cortisol, becomes higher than the desired set temperature, or homeostasis. This will cause the thermostat, or primary gland, to shut off so that the radiator, the adrenal gland, stops making heat, or any new cortisol. So secondary disorders versus primary disorders. Secondary disorder is based on the feedback mechanisms. So secondary is the pituitary gland, and tertiary would be the hypothalamic disorders that have labs in the same direction. So a TSH-secreting pituitary adenoma has increase in TSH and increase in T4 and T3. For instance, Cushing's disease, which is a pituitary adenoma, has increased ACTH and increased cortisol. Hypopituitarism has low pituitary hormones and low target hormones. Primary disorders, on the other hand, are based on feedback mechanisms. Primary disorders have labs in the opposite direction, and if the problem is in the target organ, for instance, the thyroid gland is the primary problem, you have Graves' or toxic goiter or toxic adenoma, where you have increased free T3 and T4 and a decreased TSH. For Hashimoto's and thyroiditis, for instance, you have a decreased free T4 and T3 and an increased TSH. Ovaries might be the primary problem as well in a primary disorder, such as with menopause, where there's decreased estrogen and increased FSH to LH. If the adrenal gland is the primary problem, you might have Addison's disease, which is decrease in cortisol and an increase in ACTH. And if you have an adrenal adenoma, this is an increase in cortisol and a decrease in ACTH. So tertiary, the hypothalamus is the problem. Secondary, the pituitary is the problem. Primary, the actual target organ is the problem. So next we'll go to chronic adrenocortical insufficiency. This is a disorder where the adrenal gland does not produce enough hormones. Secondary failure, again, is pituitary failure of ACTH secretion, lack of cortisol only. Aldosterone is intact due to the renin-angiotensin-aldosterone system. Etiologies are history of exogenous glucocorticoid use, and that's the most common and most important, especially without tapering. And like I said, this is the most common cause of secondary and overall insufficiency of the adrenal glands. Also hypopituitarism. That was for secondary. And for primary, which is called Addison's disease, this is the adrenal gland destruction itself, and will have a lack of cortisol and aldosterone. Etiologies include autoimmune, which is the most common cause in the US at 80%. Also infection, which is most common in developing countries, such as HIV and TB. Vascular, thrombosis or hemorrhage in the adrenal gland, like Waterhouse-Friderichsen syndrome, and others like trauma, metastatic disease, medications like ketoconazole, rifampin, phenytoin, and barbiturates. For clinical manifestations, the symptoms are due to a lack of cortisol. You'll get weakness, myalgias, fatigue, also some non-specific GI symptoms like weight or appetite loss, anorexia, nausea, vomiting, abdominal pain, and diarrhea, headache, sweating, abnormal menstruation, mild hyponatremia, salt cravings, and hypotension. Hypoglycemia is more common in secondary. So for primary Addison's disease, the symptoms are due to a lack of sex hormones and aldosterone, hyperpigmentation, also called bronze diabetes, increases ACTH, which stimulates melanocyte-stimulating hormone secretion. You also have orthostatic hypotension, as we're decreasing the ability to increase the aldosterone, so we're having a lack of sodium and an increase in potassium. So women also have loss of libido, amenorrhea, and loss of axillary pubic hair. Baseline labs, an 8 AM ACTH, cortisol, and renin levels are obtained. Increased renin, especially with primary. Elevated ACTH in primary and decreased ACTH in secondary. For labs of chronic adrenocortical insufficiency are hypoglycemia. For primary Addison's, hyponatremia, hyperkalemia, and a non-anion gap metabolic acidosis due to decreased aldosterone. The screening tests are a high-dose ACTH concentropin stimulation test. For adrenal insufficiency, it'll be insufficient or absent with a rise in serum cortisol. So there'll be no rise in serum cortisol, such as under 18 micrograms per deciliter after ACTH administration. Normal response is a rise in serum cortisol after ACTH administration. So with the concentropin test, there's insufficient or absent rise in serum cortisol. For management, glucocorticoid replacement with hydrocortisone is the first line, dexamethasone second line. Also mineralocorticoid replacement with fludrocortisone may be added only in primary Addison's disease. Patient education. Because cortisol is a stress hormone, people with chronic adrenal insufficiency must be treated with IV glucocorticoids and IV isotonic fluid before and after surgical procedures in order to mimic the body's natural response to stress hormones. During illness, surgery, high fever, oral dosing needs to be adjusted to recreate the normal adrenal gland response to stress, triple the normal oral dosing, for instance. Also, everyone should carry a medical alert tag as well as an injectable form of cortisol for emergencies. Next, adrenal Addisonian crisis, which is an acute adrenocortical insufficiency as opposed to chronic. Acute adrenocortical insufficiency, Addisonian crisis, is sudden worsening of symptoms in diagnosed or undiagnosed chronic adrenal insufficiency precipitated by a stressful event, such as illness, surgery, trauma, volume loss, hypothermia, MI, fever, sepsis, hypoglycemia, and especially steroid withdrawal. The normal response to stress is a threefold increase in cortisol, and these patients are unable to increase cortisol during times of stress to meet this demand. Etiologies, especially importantly, an abrupt withdrawal of glucocorticoids, especially without tapering, is the most common cause. Also, previously undiagnosed Addison's disease subject to stress, patients with known Addison's disease that did not increase their dosage during illness, and bilateral adrenal infarction. So they may have Addison's disease and not know they're infected with something, and then it can spiral out of control. Clinical manifestations, shock primary manifestation, hypotension, hypovolemia, and also non-specific symptoms. For labs for Addisonian crisis, you'll see a hyponatremia, a hyperkalemia, and a hypoglycemia. Cortisol and aldosterone confirms the diagnosis. Also, ACTH, renin, and CBC should be obtained. Do not delay treatment while the diagnostic testing is being performed. For management, you want to add isotonic fluids like normal saline or D5 and normal saline, plus IV hydrocortisone if known Addison's, or dexamethasone if undiagnosed because it doesn't interfere with the cortisol assays that you would need to diagnose it. Reversal of electrolyte disorders and fludrocortisone if needed. So to go over the adrenal insufficiency labs for primary adrenal, secondary pituitary, and tertiary hypothalamus. So for adrenal, which is primary, you'll have a high CRH, you'll have a high ACTH, you'll have a low cortisol, you'll have a high ACTH on the cortisol releasing hormone stimulation test. the ACH response will be high, that is, for adrenal. You'll have low aldosterone, and you'll have high renin. For pituitary or secondary, you'll have a high CRH, a low ACTH, a low cortisol, and an absent or drastically decreased ACTH on cortisol-releasing hormone stimulation test. You'll have low aldosterone and normal to low renin. Similarly, for the hypothalamus, you'll have low cortisol-releasing hormone, CRH rather. You'll have low ACTH, you'll have low cortisol, and on the cortisol-releasing hormone stimulation test, you'll have an exaggerated and prolonged effect with hypothalamic or tertiary adrenal insufficiency. Also, renin and aldosterone will be low. Note that in primary disorders, ACTH and cortisol go up in the same direction seen in secondary and tertiary. So for lab values in Cushing's syndrome, I'm going to go over the high dose dexamethasone suppression test and also ACTH. So in Cushing's disease, which is a pituitary cause, you'll have on high dose suppression test suppression of cortisol, and ACTH will also be increased. If you have an ectopic ACTH producing tumor, there'll be no suppression on high dose suppression test, but you will still have increased ACTH. If there's an adrenal tumor that's cortisol producing, again, no suppression with high dose suppression test and decreased ACTH because it's producing cortisol, so therefore it would have negative feedback and decrease the ACTH. If you're giving exogenous steroids, again, no suppression on high dose dexamethasone suppression test and also decreased ACTH for the same reasons before with the negative feedback. So note that Cushing's disease is the only one that suppresses during high dose suppression test. Next, moving into Cushing's syndrome, hypercortisolism. Cushing's syndrome is the signs and symptoms related to cortisol excess. There are four main causes: exogenous, which is long-term high-dose glucocorticoid therapy as the most common cause overall. You have endogenous, which is Cushing's disease, which is pituitary gland ACTH overproduction, whether it's hyperplasia or adenoma, most common in endogenous causes. You can also have an ectopic ACTH producing tumor, such as small cell lung cancer, importantly, or medullary thyroid cancer. Adrenal tumors, such as an adenoma, secretion of excess cortisol is also a cause of endogenous Cushing syndrome. Clinical manifestations: proximal muscle weakness, weight gain, headache, oligomenorrhea, erectile dysfunction, polyuria, osteoporosis, and mental disturbances, from mild all the way to psychosis. Physical examination of Cushing's: you'll have fat redistribution, central or truncal obesity, and moon facies, which are roundly shaped faces with puffiness and facial redness. You'll have buffalo hump, supraclavicular fat pads, and thin extremities. For skin changes, there'll be thin skin, atrophy, striae, red or purple and 1 centimeter wide. Also easy bruising, decreased wound healing, and hyperpigmentation if increased ACTH as well. You'll have acanthosis nigricans, which is epidermal hyperplasia and thickening of the skin, especially around the neck and armpits with hyperinsulinemia. Androgen excess, like hirsutism, oily skin, and acne, and also hypertension. For screening tests, there's 3 options. You can do a 24-hour urinary free cortisol, which is the most specific, a nighttime 11 p.m. salivary cortisol, or a low-dose 1 milligram overnight dexamethasone suppression test. Elevated cortisol or no suppression with low-dose dexamethasone equals Cushing's syndrome. So how do we differentiate the tests? A baseline ACTH plus high-dose dexamethasone suppression test will help distinguish Cushing's disease from other causes. And remember, Cushing's disease as opposed to syndrome, disease is a pituitary cause. So Cushing's disease, increased ACTH plus suppression of cortisol on a high dose. Cushing's disease is the only one of the 4 main causes that's suppressed with high-dose dexamethasone. Ectopic ACTH-producing tumor, increased ACTH plus no suppression with high-dose dexamethasone. Adrenal tumor and steroids, decreased ACTH plus no suppression with high-dose dexamethasone. Workup for suspected cause. After these laboratory studies, you can get a pituitary MRI if you're considering Cushing's disease, or sampling of the petrosal sinus if the MRI is negative. CT of the abdomen if you think it's an adrenal tumor. Chest imaging if you think it's an ectopic ACTH-producing lung tumor, like small cell lung cancer. And for labs, you'll see hyperglycemia, dyslipidemia, leukocytosis, hypokalemia, and metabolic alkalosis, which are due to the aldosterone-like effects of cortisol. For management overall, corticosteroid use with gradual taper and withdrawal to prevent Addisonian crisis. Cushing's disease, transsphenoidal resection. Radiation therapy can be used in inoperable pituitary tumors, also mifepristone. Adrenal tumor, tumor excision, if there's an ectopic tumor. Resection if resectable, if unresectable, ketoconazole or metapone can be used. Next will be primary hyperaldosteronism. Primary is renin-independent, autonomous, which can be idiopathic or idiopathic bilateral adrenal hyperplasia, most commonly at 60%. 40% are Cohen's syndrome, which is adrenal aldosteronoma, located in the zona glomerulosa. Some other rare causes are unilateral adrenal hyperplasia, familial or ectopic aldosterone-secreting tumor. Secondary is due to increased renin. Increased renin leads to increased aldosterone via the renin-angiotensin-aldosterone system. Renal artery stenosis is the most common type of secondary, and also renal artery hypoperfusion, such as in CHF, hypovolemia, or nephrotic syndrome. Clinical manifestations are usually asymptomatic, but they can have a triad of hypertension, hypokalemia, and metabolic alkalosis. The hypokalemia leads to proximal muscle weakness, polyuria, such as a nephrogenic DI, fatigue, constipation, decreased deep tender reflexes, and hypomagnesemia. Hypertension may manifest as a headache or flushing of the face. Patients with primary are not usually edematous. Diastolic pressures tend to be more elevated than systolic pressures. Primary hyperaldosteronism is a cause of secondary hypertension. Suspect this in patients who develop hypertension at extremes of age, such as under 30 years old or over 60 years old, not controlled on 3 blood pressure medications or with the classic triad. Screening tests, such as a plasma renin and aldosterone level, can be done. Aldosterone to renin ratio, an ARR of over 20:1. High aldosterone and low plasma renin levels equals primary. High plasma renin levels equals secondary. For labs, hypokalemia with a metabolic alkalosis, as aldosterone promotes sodium retention at the expense of potassium and hydrogen excretion. The EKG may show signs of hypokalemia, which is T-wave flattening followed by a prominent U-wave. For confirmatory tests, you can do the oral sodium loading tests, which you'll see a high urine aldosterone as primary, saline infusion test with no suppression of aldosterone levels equals primary. Also, normal response is a decrease in aldosterone levels, important to know. CT or MRI to look for adrenal or extra-adrenal mass, and sample of venous blood draining from the adrenal. High aldosterone in primary, most accurate test to distinguish between adenoma versus hyperplasia. Management of bilateral hyperplasia. You can do medical management with spironolactone or eplerenone. They block aldosterone. You can do ACE inhibitors, calcium channel blockers, or correct the electrolyte abnormalities. The management of Cohen's syndrome is surgical excision plus spironolactone, as it blocks aldosterone. Next will be pheochromocytoma. This is a catecholamine-secreting adrenal tumor from the chromaffin cells. Rare, causes 0.5% of hypertension, but most common adrenal tumor in adults. May be associated with MEN2 syndrome, neurofibromatosis 1, and von Hippel-Lindau disease. 90% of pheochromocytomas are benign, and also the rule of tens. 10% are malignant, 10% are bilateral, 10% are seen in children, and 10% are extra-adrenal, also known as paraganglioma. Pathophysiology of the pheo increases norepinephrine, epinephrine, and dopamine autonomously and intermittently, importantly. Triggers include surgery, exercise, pregnancy, medications like TCAs, opiates, metoclopramide, glucagon, and histamine. For manifestations, you have hypertension is the most consistent finding, which may be temporary or sustained, and you have PHE for pheo, which is palpitations, headache, and excessive sweating. And headache is the most common symptom, importantly. Chest or abdominal pain, weakness, fatigue, or weight loss. For diagnosis, biochemical testing with plasma fractionated metanephrines confirmed by 24-hour urinary fractionated catecholamines includes metabolites, increased metanephrines, and vanillomandelic acid. So that's important, increased metanephrines and vanillomandelic acid. For imaging, you want to get an MRI or CT of the abdomen to visualize the adrenal tumor after biochemical testing. Pre-operative management, you want to do non-selective alpha blockade as the best initial therapy. Phenoxybenzamine or phentolamine 1 to 2 weeks followed by a beta blocker or calcium channel blocker to control blood pressure prior to surgery. Think of the PHE for symptoms and management. So the PHE, palpitations, headache, and excessive sweating, as well as PHE, which is phenoxybenzamine and phentolamine. So do not initiate therapy with a beta blockade to prevent unopposed alpha constriction during catecholamine release triggered by surgery or spontaneously, which could lead to life-threatening hypertensive crisis. In patients with hypertensive crisis due to pheochromocytoma, phentolamine, nitroprusside, or nicardipine can be used to acutely lower blood pressure. Management is a complete adrenalectomy after 1 to 2 weeks of medical therapy. Next, we'll move into thyroid function tests. So for TSH, thyroid stimulating hormone, this is the best thyroid functioning test. This is the initial test for suspected thyroid disease, and it's used to follow patients on thyroid hormone treatment. A low TSH would you want to decrease the dose of levothyroxine. If they have a high TSH, we want to increase the dose of levothyroxine. Used with T4 to manage patients with Graves. Free T4 is free thyroxine levels, which is the metabolic active hormone, ordered when TSH is abnormal to determine thyroid hyperfunction or hypofunction. Thyroid antibodies can also be gotten, such as anti-thyroid peroxidase antibodies, anti-thyroglobulin antibodies, or differently, thyroid stimulating antibodies, TSH receptor antibodies. So these thyroid stimulating antibodies are specific for Graves' disease. Think they stimulate the thyroid to make it hyperthyroid, as opposed to the anti-thyroid peroxidase and anti-thyroglobulin. So this could be either autoimmune thyroiditis or Hashimoto's thyroiditis. Free T3, which is triiodothyronine. This is useful to diagnose hyperthyroidism when TSH is low and T4 is still normal. FTI, the free thyroid index, used in thyroid disease when the patient has protein abnormalities. So primary, secondary, and subclinical thyroid. Primary is the thyroid itself is the problem, and you'll have an increased TSH and a decreased free T4. So in this primary disorder, the labs are in the opposite direction. For secondary, the pituitary gland is the problem, and you'll have a decreased TSH and a decreased free T4 for secondary. In secondary and tertiary disorders, the labs are in the same direction. Subclinical, you'll have an increased TSH in hypothyroid, and for free T4, it will be normal, which is subclinical. Management is to repeat the TSH, and thyroid hormone replacement may be needed if TSH, importantly, is over 10 to reduce cardiovascular risk. So, in subclinical, you want to give thyroid hormone if the TSH is over 10. So, TSH is the initial test of choice for suspected hypo or hypothyroid conditions. The radioactive iodine test will lead to possible diagnosis, such as if it has diffuse uptake, you want to consider Graves' disease or a TSH-secreting pituitary adenoma. If there's decreased uptake of iodine, you want to think of thyroiditis, Hashimoto's, postpartum, de Quervain's. If there's a hot nodule, you want to think of a toxic adenoma. If there are multiple nodules, you want to think of a toxic multinodular goiter. If they are cold nodules, you want to rule out malignancy. So, going into clinical manifestations of hypo and hyperthyroidism. So first, starting with hypothyroidism. This is due to an iodine deficiency, could be dietary, also cretinism, Hashimoto's thyroiditis, thyroiditis such as postpartum, de Quervain's, or silent lymphocytic, which is the later stage, pituitary hypothyroidism, hypothalamic hypothyroidism, Riedel's thyroiditis, and medications like lithium, amiodarone, and alpha interferon, ALI, amiodarone, lithium, and interferon. Differently, hyperthyroidism, etiologies are Graves' disease most common, iatrogenic thyrotoxicosis, thyroiditis, postpartum, de Quervain's, silent again, but the earlier stage. So if you have thyroiditis, the earlier stage is going to be hyper, and the later stage is going to be hypo before it returns to normal. And continuing for hyperthyroidism, toxic multinodular goiter, toxic adenoma, TSH-secreting pituitary adenoma, and also amiodarone can increase thyroid as well. Also, excess intake of T3 and T4. So for clinical manifestations of both hyper and hypo, starting with hypo, we have a decreased metabolic rate. In general, all metabolic processes are decreased except for menstrual flow, which is increased. You'll have cold intolerance due to decreased heat production, and weight gain despite a decrease in appetite. For skin, there'll be dry, thickened, rough skin with loss of the 1/3 eyebrow, goiter, and non-pitting edema, myxedema. For CNS, you'll have hypoactivity, fatigue, sluggishness, memory loss, depression, decreased deep tendon reflexes, also hoarseness of the voice. For GI, you'll have constipation and anorexia. In cardiovascular, bradycardia, decreased cardiac output, and potentially pericardial effusion as well. For hyperthyroidism, clinical manifestations are an increased metabolic rate. In general, all metabolic processes are increased, except for menstrual flow, which is decreased. Heat intolerance, due to increased heat production, weight loss, despite increased appetite. And for skin, the skin is warm, moist, soft, fine hair, alopecia, and easy bruising. Also, a goiter is possible. For hyperthyroidism, you'll have hyperactivity of the CNS, anxiety, fine tumors, nervousness, fatigue, weakness, increased sympathetic tone, diarrhea, hyperdefecation in hyperthyroidism, tachycardia, palpitations, and also a potential high output heart failure. Next will be iatrogenic hypothyroidism. This is often due to treatment of hyperthyroidism with radioactive iodine or surgery, total or subtotal thyroidectomy, without subsequent thyroid hormone replacement. Amiodarone contains iodine that may induce hypothyroidism by the Wolff-Cherkoff effect, or hyperthyroidism by the Jode-Basedow effect, depending on the underlying state of the patient. Also, alpha interferon or interferon, by stimulating the immune system in patients with baseline thyroid autoimmune predisposition, such as patients with anti-thyroid peroxidase or anti-thyroglobulin antibodies. There's also lithium, mechanism that causes hypothyroidism is poorly understood, may affect the colloid. So ALI, amiodarone, lithium, iodide, or interferon too. Next, cretinism. This is untreated congenital hypothyroidism. Etiologies are a lack of maternal iodine intake in developing countries, and dysgenesis of the thyroid gland or defect in enzymes in developing countries. May be acquired if maternal TSH receptor blocking antibodies passed into the fetal circulation via the placenta, In clinical manifestations, importantly, mental developmental delays, short stature. So this is permanent, but it is preventable as well. Symptoms of hypothyroidism: decreased metabolic rate, cold intolerance, dry, thickened, rough skin, constipation, weight gain despite decreased oral intake, menorrhagia, myxedema, eyelid and facial edema, weakness, and lethargy. Goiter symptoms in older children: hoarseness and dyspnea due to tracheal compression. On physical exam, a large tongue and hernia can also be seen. Coarse facial features as well, like I said, macroglossia and umbilical hernia, as well as hypotonia due to decreased deep tendon reflexes, prolonged jaundice, feeding problems, and congenital malformations. Diagnosis is by a primary hypothyroid profile, increased TSH and decreased T4 or T3, and management is levothyroxine. Subclinical hypothyroidism: hypothyroidism determined by laboratory tests isolated increased TSH in patients with little or no symptoms. Clinical hypothyroidism may be associated with an increased risk of cardiovascular disease, especially when the serum TSH is over 10. Diagnosis is by an isolated increased TSH, hypothyroid, plus free T4 and free T3. Management: observation with follow-up TSH tests, and also you can give levothyroxine if the TSH is over 10 to prevent cardiovascular complications. Hashimoto's thyroiditis is the most common cause of hypothyroidism in the U.S., increased incidence in women 30 to 50. Pathophysiology is an autoimmune thyroid cell destruction by anti-thyroid peroxidase and anti-thyroglobulin antibodies, and TSH receptor blocking antibodies to a lesser extent. Clinical manifestations: symptoms of hypothyroidism: decreased metabolic rate, fatigue, cold intolerance, dry, thickened, rough skin, constipation, weight gain despite decreased oral intake, menorrhagia, myxedema, eyelid and facial edema, weakness, and lethargy. Goiter symptoms like hoarseness and dyspnea due to tracheal compression of the goiter. Women may have galactorrhea due to increased prolactin. On physical examination, the thyroid may appear atrophic, normal, or enlarged, like a goiter. They may have bradycardia, decreased deep tendon reflexes, and loss of the outer 1/3 of the eyebrows. Myxedema: they may have non-pitting edema, periorbital or peripheral. And for diagnosis, primary hypothyroid pattern, an increased TSH and a decreased T4 and T3. May be normal or subclinical in early disease. Positive for anti-thyroid peroxidase and or anti-thyroglobulin antibodies. On radioactive uptake scan, you'll have diffusely decreased iodine uptake. So the thyroid is slow, so it's not synthesizing as much T4 and T3, therefore it doesn't need to take up the iodine. A biopsy can also be done, but this is rare, and you'll see lymphocytic infiltration and Hürthle cells, which are enlarged epithelial cells with abundant eosinophilic granular cytoplasm. Management: levothyroxine. So levothyroxine as a drug is indicated for first-line management of Hashimoto's thyroiditis and subclinical hypothyroidism with a TSH of over 10. Thyroid hormone replacement after thyroidectomy as well. The mechanism is a synthetic T4 with a half-life of 7 days, and remember, levothyroxine is a 24-hour half-life. Monitoring: monitor TSH at 6-week intervals when initiating or changing the dose. Increase the dose if TSH is high and decrease the dose if TSH is low. So the low dose with small incremental increase should be used to initiate therapy in the elderly and patients with cardiovascular disease. During pregnancy, the dose needs to be increased due to increased thyrobinding globulin from increased estrogen binding to thyroid hormone. Thus, less is available and you need to supplement more during pregnancy. Interactions: best taken in the morning on an empty stomach for optimal absorption. Multivitamins, aluminum, iron, and calcium supplements, PPIs, should be taken at least 4 hours apart from levothyroxine, as they can decrease effectiveness. And you may need to decrease the dose with anticoagulants, insulin, and oral hypoglycemics. Cholestyramine may increase T4 requirements due to the binding of it. Adverse effects: overshoot can have adverse cardiovascular effects and cause osteoporosis. So osteoporosis due to the inadvertent increase in stimulation of PTH while stimulating the thyroid itself. So decreasing the stored calcium, increasing the serum calcium, and weakening the bone. Next, Euthyroid 6 syndrome. Abnormal thyroid function tests in patients with normal thyroid function, most commonly seen with severe non-thyroidal illnesses like sepsis, cardiac malignancies. Pathophys: severe illness decreases peripheral conversion of T4 to T3. For diagnosis, you'll have a low T3. A decreased T3 and increased reverse T3 is most common. T3 is low due to the illness-related decreased peripheral conversion of T4 into T3. Free T4 is often normal or decreased in more severe disease. TSH may be normal, low, or high. TSH is usually low with severe disease and increased in the recovery phase. For management of Euthyroid 6 syndrome, endocrine consult. Because this is a non-thyroidal illness, management is focused on treating the underlying disease illness. Thyroid hormone replacement is usually not indicated. Riedel's thyroiditis. This is a rare chronic autoimmune thyroiditis characterized by dense fibrosis that invades the thyroid and the adjacent neck structures. Part of the IgG4 related systemic diseases. So it's a slow invasion of the neck and thyroid with fibrosis, but it actually is pretty rapidly growing. So clinical manifestations present similar to the thyroid malignancy: a rock-hard, non-tender, rapidly growing fixed goiter, moves poorly with swallowing. You'll have compression symptoms with Riedel's thyroiditis, such as neck tightness or pressure, hoarseness, dysphagia, choking, coughing, increased respiratory rate from airway compression. Absence of cervical lymphadenopathy as well. For diagnosis, IgG4 serum levels, euthyroid or hypothyroid, open thyroid biopsy, and you'll have dense fibrosis. The FNA is insufficient if suspected. Biopsy is usually performed to rule out malignancy. So you want to do that open thyroid biopsy, and you'll find dense fibrosis and IgG4 serum levels. Surgical is the treatment. And for an exam tip, a rock-hard thyroid is either indicative of anaplastic thyroid cancer or Riedel's thyroiditis. A biopsy is needed to distinguish between the two. Both are fast-growing as well. Next, Myxedema coma, a rare, extreme form of hypothyroidism with a high mortality rate, over 40%. Most commonly seen in elderly women with long-standing hypothyroidism during the winter. Pathophysiology is usually an acute precipitating factor, like infection, CVA, CHF, sedative or narcotic use, in a patient with long-standing hypothyroidism, discontinuation or non-compliance with levothyroxine therapy, or failure to start levothyroxine after treatment for hyperthyroidism. Clinical manifestations: severe signs of hypothyroidism, bradycardia, obtundation, coma, hypothermia, hypoventilation, hypotension, hypoglycemia, hyponatremia. Diagnosis is by a hypothyroid profile with increased TSH and a decreased free T4. Free T3 and T4 levels may be so low that it may be undetectable. You can also check a serum cortisol. Management: IV thyroid hormone replacement, levothyroxine plus supportive. So this is IV, not oral. ICU admission: passive warming, like rapid warming, is contraindicated. IV normal saline and IV glucocorticoids are often given. So levothyroxine IV, corticosteroids, IV fluids, and warming. Subacute granulomatous or Dacre veins thyroiditis. Pathophysiology: unknown but often antecedent viral respiratory tract infection or post-viral inflammation, but it is not an autoimmune disease. Hyperthyroidism is typically the initial presentation, followed by euthyroidism, then hypothyroidism, followed by resolution and restoration of normal thyroid function. So the hyperthyroidism basically burns itself out, becomes hypo, and then resets back to normal. Clinical manifestations: painful thyroid gland, aggravated with head movement and swallowing. Usually starts in the lower neck and radiates to the jaw and ear. Patients usually present in hyperthyroid phase due to acute neck pain. They may have URI symptoms like fever, myalgias, malaise, and fatigue. On physical examination, there'll be a diffusely tender goiter. For diagnosis, a high ESR, although it's not autoimmune, and negative thyroid antibodies. So high ESR, negative thyroid antibodies. Hyperthyroid profile early in the disease, with a decreased TSH and an increased free T4, may present in a euthyroid or later in a hypothyroid state. This is for subacute, granulomatous, or Descurvain's thyroiditis. Adjunctive diagnosis, radioactive uptake scan, will show diffuse decreased iodine uptake, similar to Hashimoto's and postpartum thyroiditis. Biopsy will show granulomatous inflammation with multinucleated giant cells, although this is rarely performed. Management is supportive, reassurance that it is self-limited, 95% return to a euthyroid state, NSAIDs or aspirin for acute pain and inflammation. Prednisone is an alternative if no response to NSAIDs or in severe pain. Next is Graves' disease. Graves' disease is the most common cause of hyperthyroidism in the U.S. The highest incidence is in between 20 and 40 in women. Pathophysiology, autoimmune disease. TSH receptor autoantibodies target and stimulate this TSH receptor on the thyroid gland, leading to an increased thyroid hormone production, thyroid gland enlargement, and hyperthyroidism. Ophthalmopathy. TSH receptors autoantibodies activate retroocular fibroblasts and adipocytes, leading to orbitopathy, specific to Graves. Clinical manifestations, symptoms of hyperthyroidism, palpitations, heat intolerance, tremors, weight loss, AFib especially, and specific to Graves. Ophthalmopathy, proptosis, exophthalmos, lid lag, diplopia, and vision changes. They could have pretibial myxedema with swollen red or brown patches on the legs with non-pitting edema. And physical exam will show a diffusely enlarged non-tender goiter and a thyroid bruit. Diagnosis is a primary hyperthyroid profile with a decreased TSH and an increased free T4 or T3. Positive thyroid stimulating immunoglobulins, TSH receptor autoantibodies, are hallmark. On radioactive uptake scan, a diffused increased iodine uptake. So basically more iodine demand by the tissue due to the increased T4 production. Management, radioactive iodine. Most common therapy used. Ablates the thyroid within 6 to 12 weeks. May exacerbate ophthalmopathy initially, contraindicated in pregnant and lactating women. Thionomides, methimazole, or propylthiouracil. The mechanism of action is prevents thyroid hormone synthesis, will often achieve a euthyroid state within 3 to 6 weeks. May be used in older patients or patients with cardiovascular disease. May also be used prior to more definitive treatment, like a thyroidectomy or radioactive iodine. PTU also prevents peripheral conversion of T4 into T3. Adverse effects: agranulocytosis, aplastic anemia, and fulminant hepatitis. Methimazole is generally preferred, less adverse effects, but teratogenic in the first trimester, importantly. Propylthiouracil, preferred in the first trimester and for thyroid storm. Beta blockers can also be used, such as propranolol, can be used to rapidly ameliorate symptoms such as tremor, hypertension, AFib, and tachycardia. In ophthalmopathy, glucocorticoids are the best initial therapy. Radioactive iodine may exacerbate initially, so glucocorticoids usually employed prior to radioactive iodine in severe ophthalmopathy. Decompressive therapy and orbital radiotherapy are other options. TSH-secreting pituitary adenoma. So first, actually, the treatment of Graves' disease is big T. So B, beta blockers, I, iodine, G, glucocorticoids, T, thionomides. Next, for TSH-secreting pituitary adenoma. Benign pituitary adenoma that secretes TSH in an autonomous fashion. Rare cause of hyperthyroidism, under 1% of all cases. Clinical manifestations, a diffuse goiter, 95%. Signs of hyperthyroidism, anxiety, heat intolerance, weight loss despite appetite, fatigue, weakness, increased sympathetic output, tachycardia, palpitations, AFib, fine tremor, diarrhea, increased metabolic rate, high output heart failure, and oligomenorrhea, decrease in menstruation. Compression of local structures from a pituitary adenoma. You'll have bitemporal hemianopsia, loss of the outer visual fields of both eyes, due to compression of the optic chiasm, headache, and mental disturbances as well. Diagnosis, secondary hyperthyroid profile, increased TSH and increased free T4, both in the same direction, as it's a secondary cause. Radioactive uptake scan, diffuse increased uptake, same as Graves. Pituitary MRI to detect adenoma, and an increase in alpha subunit distinguishes TSH resistance syndrome. Management is a transsphenoidal surgery, which is definitive, and also somatostatin analogs may be used prior to surgery to restore euthyroidism. Next, toxic adenomas. Single or multiple hyperfunctioning autonomous nodules. Non-toxic, usually asymptomatic. Toxic equals symptoms of thyrotoxicosis. Clinical manifestations, signs of hyperthyroidism, anxiety, heat intolerance, weight loss despite increased appetite, etc. High output heart failure, oligomenorrhea. Obstructive symptoms due to an enlarged goiter, dyspnea, dysphagia, stridor, hoarseness, if the goiter presses on the recurrent laryngeal nerve, importantly, for toxic adenoma. Physical exam, a palpable thyroid nodule, and for diagnosis, a primary hyperthyroid profile, decreased TSH and increased free T4 or T3, may be subclinical or normal. Radioactive iodine scan, single or multiple areas of increased iodine uptake, hot nodules, with decreased uptake in the surrounding normal tissue. You can also do an ultrasound. Management, radioactive iodine ablation or surgery usually preferred over long-term antithyroid medications like PTU or methimazole. Surgery for compressive symptoms. Next will be suppurative thyroiditis. This is a bacterial infection of the thyroid gland by gram-positive bacteria, Staph aureus most common, or gram-negatives as well, pneumocystis and mycobacterial. It's very rare and usually occurs in children. Clinical manifestations are thyroid pain and tenderness, sudden onset of neck pain and tenderness to the thyroid gland. The pain is often worse with hyperextension and improves slightly with neck flexion, may radiate to the mandible, ears, or posteriorly, may have an overlying erythema to the skin. Importantly, fevers, chills, pharyngitis, dysphagia, dysphonia, and hoarseness may present. Diagnosis, on labs you'll have leukocytosis with an increased ESR, and thyroid function tests are usually normal for suppurative. Fine needle aspiration with a gram staining culture should be done, or a thyroid ultrasound. Management, antibiotics, and surgical drainage if it is fluctuant. So remember, is it a rock hard nodule of the suppurative thyroiditis, which is anaplastic or Riedel's? Or is it a painful, like granulomatose or Descraven's? So here, exam tip says, the only two causes of painful thyroid are subacute, granulomatose, Descraven's, and suppurative thyroiditis. Next, thyrotoxic crisis, thyroid storm. Rare, potentially fatal complication of untreated or partially treated thyrotoxicosis, usually after a precipitating event. Surgery, trauma, infection, pregnancy. Only 1 to 2% of patients with hyperthyroidism present with thyroid storm, 75% mortality. Clinical manifestations, hyperthyroid symptoms and a hypermetabolic state. Cardiovascular dysfunction, palpitations, tachycardia, AFib, and CHF. They also have a very high fever, 104 to 106, nausea, vomiting, and tremors. CNS dysfunction, agitation, delirium, psychosis, coma, which later may progress to coma and hypotension. May have symptoms of hyperthyroidism, warm or moist skin, hand tremor, For diagnosis, primary hyperthyroid profile, increased free T4 or T3, plus a decreased TSH, may be low, it may be undetectable. Most common pattern, hyperglycemia may also be seen. So management is IV fluids, propranolol, plus antithyroid medications like PTU or methimazole, but PTU is preferred, plus IV glucocorticoids. So again, beta blockers, iodide, glucocorticoids, and thionamides, and that's PTU. But first you want to do propranolol in thyrotoxic crisis. So beta blockers reduce the tachycardia and decrease adrenergic symptoms. Antithyroid medications block the synthesis of new T3 and T4. PTU is preferred over methimazole because PTU also reduces peripheral conversion of T4 to T3. And glucocorticoids also reduce peripheral conversion of T4 to T3. This is followed by oral or IV sodium iodide 1 hour after the PTU. Iodinated radiocontrast agent. Iodine's solution blocks the release of thyroid hormone itself, and iodinated radiocontrast agents. Glucocorticoid reduces peripheral conversion of T4 to T3. Antipyretics given. Avoid aspirin because it can displace thyroid hormones off the carrier proteins, and also cooling blankets. Next, we'll go into the different variations of thyroid cancer. So first will be papillary thyroid carcinoma. This is the most common thyroid cancer, over 80%, and more common in women, but the prognosis is worse in men. It's the least aggressive and has an excellent prognosis. Metastasis usually occurs locally, cervical lymph nodes, and distant mets are uncommon. Usually presents as a painless thyroid nodule, and risk factors are most common after radiation exposure or a family history of thyroid cancer. The workup is a fine needle aspiration because thyroid functional tests are usually normal. Management is a thyroidectomy, total or near total, usually followed by post-op levothyroxine. Next will be follicular thyroid carcinoma. This is the second most common at 10%. It's more aggressive than papillary, but slow growing, and it's more common at 40 to 60 years old. Risk factors: increased incidence with iodine deficiency, less often associated with radiation exposure compared to papillary. Metastasis: distant mets are more common than local mets. Hematogenous spread in follicular. The lungs are most common, also the liver, brain, and bone. Think follicular goes far. Diagnosis: FNA, with biopsy often alone cannot distinguish between follicular from carcinoma, so definitive diagnosis is made post-surgical histologic testing. Management is a thyroidectomy, total or near total, followed by post-op levothyroxine. Post-surgery radioiodine in some patients, and post-treatment may monitor thyroglobulin levels, TSH, and ultrasounds of the neck. So follicular hematogenous spread goes far and a little bit more common than papillary. Next, medullary thyroid carcinoma. 5% of all thyroid carcinoma. It's derived from calcitonin synthesizing parafollicular C cells. 90% are sporadic, 10% are associated with men 2A or 2B. More aggressive, local cervical node mets in the early disease with distant mets in later disease. For labs, an increased calcitonin. Management and a decreased calcium. Management: total thyroidectomy, may include dissection of lymph nodes and surrounding fatty tissue on the ipsilateral side. May order urinary metanephrines to rule out pheochromocytoma, since they are more likely to have a men 2A or 2B syndrome. Prognosis is worse than papillary or follicular, and calcitonin levels are used to monitor for recurrence or residual disease. So remember, calcitonin, decreased calcium, associated with men 2A or 2B. Next, and lastly, will be anaplastic thyroid carcinoma. Rare, most commonly seen in elderly over 65 years old, most aggressive of all thyroid cancers, and this has the poorest prognosis. It has rapid growth and compressive symptoms like dyspnea and dysphagia, and this will have again a rock-hard thyroid mass, may be fixed. Most are not amenable to surgical resection. External beam radiation or chemo can be done. Often a palliative tracheostomy may be needed to maintain the airway. So papillary, follicular, medullary, and anaplastic. Next will be thyroid nodule. Over 90% of nodules are benign. Most thyroid nodules are in women, are benign as well. Follicular adenoma or cyst. Only 10% are malignant or even suspicious. Risk factors are extremes of age, very young or over 60 years old. Also history of head and neck irradiation, importantly. For benign nodules, follicular adenoma from the colloid is most common type at 50 to 60%. Also adenomas, cysts, and localized thyroiditis. Clinical manifestations, most are asymptomatic. Compressive symptoms, difficulty swallowing or breathing, neck, jaw, or ear pain, hoarseness from recurrent laryngeal nerve impingement. Functional nodules are rare, presents with thyrotoxicosis. On physical exam, benign are varied, smooth, firm, irregular, sharply outlined, discrete, and painless. For malignant, however, they're rapid growth, fixed in place, no movement with swallowing. Riedel's thyroiditis may also present like this. For workup, you want to do thyroid functional testing first, often the initial test done as part of a nodule workup. If TSH is subnormal, subclinical, or overt hyperthyroidism, order a thyroid scintigraphy, which is a radioactive iodine uptake scan. If TSH is normal or high, FNA with biopsy is indicated. So first TFTs, then biopsy if indicated. Thyroid ultrasound, usually performed after TFTs in patients with nodules. High-resolution ultrasound is the most sensitive test in the detection of the presence of a thyroid lesion. Often used to determine if FNA with biopsy is needed, help obtain a specimen during FNA with biopsy, used to see if the nodule is cystic or solid, to monitor a suspicious nodule, or to see if a nodule is growing or shrinking, and that's thyroid ultrasound. The ultrasound findings suspicious of cancer include irregular margins, hypoechoic, central vascularity, and documented nodule growth. Fine needle aspiration is the best test to evaluate the etiology of a nodule, may be guided by ultrasound. FNA performed in nodules over 1.5 centimeters with normal TSH, or in highly suspicious nodules via ultrasound or examination. Radioactive iodine uptake scan, usually performed if the FNA is indeterminate or if low or subnormal TSH. Cold nodules, no or low iodine uptake, should be biopsied to rule out malignancy. Functioning or normal or hot nodules have a lower malignant potential. Management is surgical excision if thyroid cancer is suspected, or if an indeterminate FNA, especially with cold scan. Observation plus follow-up ultrasound if surgery is not performed, usually every 6 to 12 months. Next, we'll move into diabetes. Type 1 diabetes is insulin deficiency due to pancreatic beta islet cell destruction. These patients require exogenous insulin. The onset is usually under 30 years of age. 3/4 are diagnosed in childhood. Peaks at ages 4 to 6 and then 10 to 14. Not associated with obesity. Etiologies are type 1A, which is autoimmune, which is the most common. This is often triggered by environmental factors like infection, increased with HLA-DR3, DQ2, and DR4 genes. Type 1B is a non-autoimmune beta cell destruction. Clinical manifestations of type 1 are hyperglycemia without acidosis, most common initial presentation, polyuria, polydipsia, polyphagia, weight loss, and lethargy. Diabetic ketoacidosis is the second most common initial presentation, more common in type 1. Hyperglycemic hyperosmolar syndrome, HHS, is more common in type 2. Also, a silent asymptomatic incidental discovery is possible with type 1. Type 2, on the other hand, is a combination of insulin insensitivity and relative impairment of insulin secretion. Increased insulin levels early in the disease, but may diminish with disease progression. Risk factors, likely due to genetic and environmental factors especially with obesity as the greatest risk factor and decreased physical activity. 90% of type 2 diabetics are overweight, most common in over 40 years old. History of impaired glucose tolerance, family history, first-degree relative, Hispanic, African American, Pacific Islander, hypertension, dyslipidemia, delivery of a baby over 9 pounds, syndrome X, and insulin resistance. So importantly is chronic hypertension, atherosclerosis, obesity, central, and stroke. Clinical manifestations of type 2, most are asymptomatic, may be an incidental finding, but you also have classic symptoms of polyuria, polydipsia, and polyphagia. You also have poor wound healing, increased infections as well, and you could have a presentation of hyperglycemic hyperosmolar syndrome. So now going over some of the levels and diagnosis of diabetes type 2. So on a fasting plasma glucose, impaired tolerance is 110 to 125, and diabetes can be diagnosed on a fasting on 2 occasions, which is the gold standard, fasting of at least 8 hours on 2 separate occasions of over 126, greater than or equal to 126 for fasting. On a 2-hour glucose tolerance test, the impaired tolerance is greater than or equal to 140 to 199, and a 3-hour glucose tolerance test is done in gestational diabetes, but diagnosis for a 2-hour glucose tolerance test is greater than or equal to 200. A hemoglobin A1C impaired is 5.7 to 6.4%, and greater than or equal to 6.5 indicates a diagnosis of type 2. So this indicates the average blood sugar and 10 to 12 weeks prior to measurement. A random plasma glucose over 200 in a patient with classic diabetes symptoms or complications is also diagnostic. So it can be either over 200 on the 2-hour glucose tolerance test, or it can be over 200 in a random plasma glucose, but they must have the classic diabetic symptoms or complications associated with that. And remember that fasting plasma glucose has to be done 2 occasions 8 hours apart, and that's the gold standard. Next is screening. So the American Diabetes Association says all adults over 45 every 3 years, or any adult with a BMI over 25 plus 1 additional risk factor. The USPSTF in 2015 says anybody 40 to 70 years old that is overweight or obese should do it every 3 years. So the initial management of type 2 diabetes. Diet, exercise, and lifestyle changes are the initial management of type 2. Carbohydrates 50 to 60%, protein 15 to 20, and 10% unsaturated fats. Oral anti-hyperglycemic medications initiated if unable to control glucose with lifestyle changes, such as metformin as the initial therapy. You can also use sulfonylureas, meglitinides, TZDs, DPP-4 inhibitors, GLP-1 agonists, SGLT2 inhibitors. Insulin may be needed if uncontrolled with other medications. So now we'll go into all the different type 2 diabetes medications. First, biguanides, which are metformin. Mechanism of action, the major effect is decreased hepatic glucose production, so the inhibiting of gluconeogenesis. Increases insulin-mediated glucose utilization in the peripheral tissues. Because it has no effect on pancreatic beta cells, it is not associated with hypoglycemia. It's also not associated with weight gain. Indications for metformin are usually first line in oral medication in type 2. It can decrease the hemoglobin A1C by 1.5% and glucose concentrations by approximately 20%. Additional benefits in metformin include weight loss, decreased triglycerides, and decreased cardiovascular risk, and possibly decreased cancer risk as well. Adverse effects, importantly, GI complaints are the most common, with metallic taste, diarrhea, abdominal discomfort, and nausea. Also vitamin B12 deficiency due to decreased B12 absorption, lactic acidosis as well, Tends to occur in patients predisposed to hypoxemia, hypoperfusion, heart failure, or severe renal or hepatic impairment, for lactic acidosis, importantly. And metformin is contraindicated in severe renal or hepatic impairment or heart failure. Metformin is often held before giving iodinated contrast and may be resumed 48 hours with monitoring of creatinine, importantly. Next, sulfonylureas. Second generation sulfonylureas are the most commonly used, like glipizide, glyburide, and glimepiride. The first generation, like tobutamide and chloropropamide, they're not often used as common because of their side effects. Like chloropropamide has hyponatremia as a side effect, and remember that's a treatment for nephrogenic DI. The mechanism of action of sulfonylureas stimulates pancreatic beta cell insulin release. It's an insulin secretagogue via mimicking the action of glucose, leading to closure of the potassium ATPase channel. Second generation are preferred because they're associated with less adverse effects and a shorter duration of action. Indications: in addition to metformin or as a single initial therapy in patients with contraindications to metformin. They have a similar glycemic effect compared to metformin. Short-acting glimepiride or glipizide is safer in patients with chronic renal disease. Adverse effects: hypoglycemia, the most common adverse effect, especially with the long-acting first generation, because the insulin release is non-glucose dependent, unlike other ones. Adverse effects: hypoglycemia is the most common adverse effect of sulfonylureas, especially with the long-acting first generation. GI upset, dermatitis, sulfonamide allergies, importantly weight gain, CP450 system inducer, and chloropropamide has two unique adverse effects: hyponatremia and disulfiram reaction, flushing reaction after alcohol ingestion, by inhibiting the metabolism of acetaldehyde. So chloropropamide is the hyponatremia and disulfiram reaction. Otherwise, hypoglycemia are the main side effect for sulfonylureas and weight gain. Next will be the meglitinides, which are similar to sulfonylureas but with no sulfa. This is repeglitinide and netaglinide. Mechanism of action: stimulates pancreatic beta cell insulin release, once again an insulin secretagogue that is more glucose dependent, leading to a postprandial insulin release. Indications: may be used as monotherapy with contraindications to metformin or in combo with metformin. They have similar benefits to sulfonylureas without the sulfa component, so they're safer in patients with sulfa allergies. Hypoglycemia has a lower incidence compared to sulfonylureas, although it's still a side effect. Weight gain, of course, and repeglinide is safer in patients with chronic renal disease, as it's primarily metabolized by the liver. Next, TZDs, like pioglitazone and rosiglitazone. Mechanism of action: decreased insulin sensitivity at the peripheral receptor site, adipose, muscle, and liver, leading to increased glucose utilization and decreased glucose production. No effect on pancreatic beta cells. The A1C falls almost 2% with monotherapy. But importantly, the adverse effects of TZDs are peripheral edema and fluid retention, also congestive heart failure and increased fractures. Hepatotoxicity, very important while on this medication. And rosiglitazone is often associated with higher incidence of cardiovascular events and atherogenic lipid profiles. Bladder cancer with pioglitazone as well. Contraindications: heart failure, history of bladder cancer, active liver disease, and high risk of fractures. So with TZDs, the pioglitazone, just remember bladder cancer, pioglitazone, and rosiglitazone is cardiovascular. Alpha glucosidase inhibitors like acarbose and miglidol. Mechanism of action is delays intestinal glucose absorption. So it inhibits the pancreatic alpha amylase and intestinal alpha glucosidase hydrolase. Does not affect insulin secretion, not associated with hypoglycemia, although it's much less potent than metformin or sulfonylureas. Adverse effects are GI, flatulence, diarrhea, abdominal pain, and hepatitis, and cautious use in patients with gastroparesis, inflammatory bowel disease, or on bile acid sequestrants. That's alpha alpha-glucosidase inhibitors. Next, glucagon-like peptide receptor agonists, or GLP-1s. This is liraglutide, exenatide, and dulaglutide. The mechanism of action is mimics incretin, leading to increased glucose-dependent insulin secretion, decreasing glucagon secretion, as well as delaying gastric emptying, and this is administered via an injection. Associated with weight loss and reduction of major cardiovascular events, especially liraglutide. Not associated with hypoglycemia when used as monotherapy. And so you can remember it as GLP-1s are the tides. One person said gooey laundry pod, GLP, and tide laundry pods. Adverse effects of the GLPs are GI and pancreatitis. Small risk of hypoglycemia, but usually only when you add other hypoglycemic agents to it. GLPs are contraindicated with a history of gastroparesis or pancreatitis, as well as medullary thyroid carcinoma, or MEN2 syndrome, as that also has pancreatic risk cancer in it too. DPP-4 inhibitors like sitagliptin, linagliptin, and other gliptins. Mechanism of action: DPP-4 inhibition causes decreased degradation of GLP-1, increasing GLP-1 levels. This leads to increased insulin release, decreased glucagon, decreased hepatic glucose production, and increased uptake of glucose in the peripheral tissues. It's not associated with hypoglycemia if not used with insulin secretagogues. Indications: monotherapy in patients who are intolerant or have contraindications to other oral medications, can be used as adjunctive to those medications. Adverse effects similar to the GLPs, like headache, acute pancreatitis importantly, hepatitis, skin changes, renal dysfunction. Next, importantly, is the SGLT2 inhibitors. These are flozin, empagliflozin, canagliflozin, and dapagliflozin. Flozin out the kidneys, you can think about. Mechanism of action: sodium glucose transport, SGLT2, inhibition lowers renal glucose threshold, leading to increased urinary glucose excretion. SGLT2 is expressed in the proximal tubule and mediates reabsorption of approximately 90% of the filtered glucose load. They are relatively weak glucose-lowering agents. They're not associated with hypoglycemia in the absence of therapies other than otherwise cause hypoglycemia. Indications: most often used in combination with metformin, pioglitazone, sitagliptin, or insulin. Cardiovascular risk reduction: improves cardiovascular outcomes and decreases the risk of heart failure, especially empagliflozin. So it's good for diabetes and decreasing the rate of kidney failure associated with diabetes. Added benefit of blood sugar control, blood pressure control, and weight reduction. Adverse effects: transient nausea and vomiting, thirst, abdominal pain, acute kidney injury and bone injuries, UTIs, and yeast infections, most importantly. They may cause some hypotension in patients with hypertensive medications due to the osmotic diuresis, and at the initiation of therapy, should avoid hypoglycemia by monitoring A1C. Contraindications and cautions: not used in type 1 or a type 2 with a GFR under 60, importantly. Cautious with other medications that can cause dehydration as well. So next we'll go over different types of insulin. So we'll go over the type of insulin, the speed at which it works, and the coverage. So first, the rapid acting types of insulin don't lag. So LAG, Lispro, Aspart, and Glulisine. Lispro is Humalog, Aspart is Novolog. The onset of these rapid acting are 5 to 15 minutes. They peak at 45 to 75 minutes, and they last 2 to 4 hours. They're given at the same time of meals, often used with intermediate or long-acting insulin. The regular short-acting, which is regular, has an onset of 30 minutes, peaks in 2 to 4 hours, and lasts 5 to 8 hours. This is given 30 to 60 minutes prior to a meal, often used with intermediate or long-acting. Next is intermediate type of insulin, which is NPH or Lente. Onset takes 2 hours, peaks in 4 to 12 hours, and lasts 8 to 18 hours. This intermediate NPH Lente covers insulin for about a half day or overnight, often combined with rapid or short-acting insulin. NPH is often given at bedtime. For long-acting, this is Detamir and Glargine. These have an onset of 2 hours. They peak in 3 to 9 hours, and Glargine has no peak. Detamir peaks in 3 to 9 hours. And Detamir has 6 to 24 hour duration, whereas Glargine is over 20 to over 24 hours duration. Covers insulin for 1 full day. This is a basal insulin. Again, Detamir, 6 to 24 hours. Glargine causes fewer hypoglycemic episodes than NPH, and long-acting should not be mixed with other types of insulin in the same syringe itself. Pre-mixing, Humalog 70/30 between NPH and regular. Humalin, rather, 70/30 NPH and regular. Novolin is 70/30. Novolog is 70/30 NPH and aspart, and Humalin is 50/50. That's pre-mixed. These are generally given twice daily before mealtime, 70/30 NPH and regular. Next will be the Somogyi and Dawn effect. So a few tips on this are, in answering these questions, if the 11 p.m. dose is usually normal and the 8 a.m. preprandial dose will be high, the key is what is the 3 a.m. dose. If it rises in the sun at 3 a.m., it's the dawn phenomenon. If the 3 a.m. dose is low, hypoglycemia, then it is Somogyi. Okay, Somogyi phenomenon, nocturnal hypoglycemia, followed by rebound hyperglycemia. The pathophysiology of this is hyperglycemia occurs due to surge in growth hormone after early AM hypoglycemia. Management, prevent the hypoglycemia with any one. Decrease nighttime NPH, move the evening NPH earlier, give a bedtime snack. So basically, growth hormone realizes the nocturnal hypoglycemia and increases glucose so that in the AM there will be some blood sugar increase. As opposed to the Somogyi, the dawn phenomenon is between 2 and 8 a.m. So normal glucose until the rise in serum glucose levels between 2 a.m. and 8 a.m. Pathophysiology results from decreased insulin sensitivity and nightly surge of counter-regulatory hormones during nighttime fasting. Management of dawn phenomenon, reduce early morning hyperglycemia with any one, bedtime injection of NPH to blunt the morning hyperglycemia, increase the NPH dose, and avoiding carbohydrate snack late at night. The insulin pump usage early in the morning. Insulin waning, progressive rise in glucose from bed to morning, seen when NPH dose in the evening is administered before dinner, due to ineffective dosing of NPH insulin. Management, move the NPH insulin dose to bedtime or increase the evening dose. And don't forget, no C-peptide in diabetes type 1 due to exogenous production, and a C-peptide is present in diabetes type 2. So in Somogyi, you want an increase in glucose. In dawn, you want a decrease in glucose. Next will be hypoglycemia itself. This is a blood glucose level of 70 or less. A complication of the management of diabetes, usually due to too much insulin use or too little food or excess exercise, one of those three. Clinical manifestations, autonomic symptoms, sweating, tremors, palpitations, nervousness, tachycardia, pallor, and cool, clammy skin. CNS effects of hypoglycemia, headache, lightness, confusion, slurred speech, dizziness, irritability, difficulty concentrating, blurred vision, nausea, and syncope. Management of mild to moderate, 15 to 20 grams fast-acting carbohydrate, fruit juice, and hard candies. Recheck in 10 to 15 minutes. Severe or unconscious, which would be under 40 milligrams per deciliter of glucose. of hypoglycemia, you want to do an IV bolus of D50 or IV glucagon. Glucagon subQ or IM if no IV access. If unknown cause, order a C-peptide, plasma insulin levels, and an anti-insulin antibodies as part of the workup. An elevated C-peptide is seen in endogenous insulin production. C-peptide is normal with exogenous insulin administration. So, like we said, C-peptide is present with type 2, and there will be no C-peptide in diabetes type 1. Next will be the all-important DKA, diabetic ketoacidosis. This is a consequence of insulin deficiency and counter-regulatory hormone excess. It's most commonly seen in type 1 diabetes due to the insulin deficiency, and the etiologies are due to stressful triggers. Infection is the most common cause, like UTI or pneumonia, discontinuation or inadequate insulin therapy, undiagnosed diabetes, MI, CVA, pancreatitis as well. Clinical manifestations of DKA: polyuria, polydipsia, nocturia, weakness, fatigue, altered mental status, nausea, vomiting, chest pain, and importantly, abdominal pain, diffuse mid-abdominal pain. Physical examination: tachycardia, tachypnea, hypotension, decreased skin turgor, fruity or acetone breath, and Kussmaul respirations. So don't forget, DKA is Kussmaul respirations. These are deep, continuous respirations. Diagnosis: the plasma glucose will be over 250, but usually not greater than 600, a decreased arterial pH under 7.3, and a bicarb under 22, due to a high anion gap metabolic acidosis. Increased serum osmolality, due to the increased sugar, positive ketones in the urine, and serum. So you'll have an increased beta hydroxybutyrate as well. Your management is SIPS, S-I-P-S. Saline, insulin, potassium, and search for the underlying cause. So you want to use the insulin that you want to use as regular, not rapid acting, and you want to do the potassium repletion and measure the potassium before you give any insulin. So IV fluids are the critical initial step. So if they ask what is the first initial step in DKA management, you definitely want to give normal saline first until hypotension and orthostasis resolves. Then switch to half normal saline, 0.5%, 0.45%. When glucose levels become 250 or less, use D5 version of the current solution to prevent hypoglycemia from all the insulin that you're about to give. Regular insulin, not lag, lispro, aspartame, lowers the serum glucose and switches the body from a catabolic to an anabolic state, reduces ketones and fatty acid production, as well as decreases gluconeogenesis. So importantly to know about how to replete the potassium. So despite the serum K+ levels, the patients are always in a total body potassium deficit. The correction of DKA will invariably cause hypokalemia. So unless the serum potassium is over 5.3 milliequivalents per liter, K+ repletion is recommended. If the serum K+ is between 3.3 and 5.3, IV potassium chloride at 20 to 30 milliequivalents per liter is added to each liter of IV fluid replacement. That's if it's between 3.3 to 5.3. If the serum potassium is under 3.3, IV potassium chloride 20 to 40 milliequivalents per liter should be given. If the serum potassium is over 5.3, delay replacement until the potassium falls below 5.3. And you want to check the serum K+ levels hourly. So treatment goals. Goal is closing the anion gap in DKA to determine the complete management. And bicarb levels more important than glucose levels in determining the severity of DKA. So the DKA should really fix itself when other things are fixed in response to it. Bicarbonate administration is only used in severe cases because it is associated with complications such as overcorrection and increased cerebral edema. So next we'll compare diabetic ketoacidosis, which with hyperosmolar hyperglycemic state, HHS, consequence of insulin deficiency and counter-regulatory hormone excess. HHS is more common in type 2 diabetics, seen in older patients, and associated with more severe dehydration and a higher mortality compared to DKA. Etiologies of HHS is a response to stressful triggers, infection the most common cause, UTI or pneumonia, undiagnosed diabetes, MI, CVA, and pancreatitis. Pathophysiology of HHS is illness leading to reduced fluid intake, infections the most common, leading to profound dehydration, increased osmolarity, hyperglycemia, and a total body potassium deficit. HHS is not usually associated with severe ketosis or acidosis because they still make enough insulin to prevent the ketogenesis, but not enough to actually pull the sugar into the cell. Clinical manifestations: hyperglycemia, increased thirst, polyuria, nocturia, weakness, fatigue, confusion, nausea, vomiting, and altered mental status. On physical exam of HHS, tachycardia, tachypnea, hypotension, decreased skin turgor due to the dehydration, dry mouth and increased cap refill. Time. Diagnosis: increased osmolarity over 320 and an increased serum glucose over 600. Also the absence of significant acidosis. The arterial pH should still be over 7.3 and the serum bicarb over 15. So the bicarb stays normal in this one. The management is still SIPs, saline as the most important component of treatment, insulin, importantly regular insulin, potassium repletion, and search for the underlying cause. So to compare lab values of HHS and DKA, for plasma glucose, HHS over 600 and DKA over 250, the arterial pH in HHS will be over 7.3, and in DKA it will be under 7.3, mild DKA under 7.3, moderate 7.0 to 7.24, and severe under 7.0. Bicarb will be over 15 in HHS, DKA 15 to 18, 10 to under 15, and severe DKA under 10 bicarb. Ketones, small to none in HHS, and they'll be positive in DKA, and the serum osmolarity will be over 320 in HHS and variable in DKA. Next will be the complications of diabetes. First, cardiovascular complications. Atherosclerosis, diabetes is considered a coronary artery disease equivalent. Also peripheral artery disease. Stroke, risk is 2 to 4 times greater than the general population in diabetics. Congestive heart failure and cardiomyopathy. Hypertension, the blood pressure goals in diabetes are under 140 over 90. Also no ACE inhibitors or ARBs if the blood pressure 140 over 90 or greater, or urine is positive for microalbuminuria. Cardiovascular risk reduction, aspirin should be used in patients over 30. Statin medication when LDL is under 100. Reduce other cardiac risks, and a hemoglobin A1C under 7%. Diabetic neuropathy, many forms of diabetic neuropathy including symmetric polyneuropathy, which is the most common type of diabetic neuropathy, progressive distal sensory loss in a stocking glove pattern involving the distal lower extremities first, progressing to the hands. They'll have loss of vibratory, proprioception, light touch, and temperature. Decreased ankle reflexes, gait abnormalities, and motor dysfunction can occur. May lead to foot ulcer formation, importantly. So remember, symmetric polyneuropathy, stocking glove, and foot ulcers. Autonomic diabetic neuropathy, they may have orthostatic and postural hypotension, also gastroparesis, but this may occur after many years, and enteropathy, constipation or diarrhea. A cranial mononeuropathy, most commonly affecting the extraocular muscles, such as cranial nerve 3, the oculomotor. They may have diplopia and ptosis with sparing of the pupils, unlike other cranial nerve 3 palsies. Cranial nerve 6, the abducens, or 4, the trochlear nerve. Cranial nerve 7, the facial nerve palsies as well could occur. Peripheral mononeuropathy, the median nerve neuropathy is most common, resulting in carpal tunnel syndrome for these diabetics, and also ulnar neuropathy. Management is optimal glucose control, Pregabalin and duloxetine, an SNRI, are FDA approved for this as well. Amitriptyline, a TCA, or gabapentin can be used. Second line is venlafaxine, another SNRI, or topical agents like capsaicin cream and lidocaine patches, as well as alpha-lipoic acid and transcutaneous electrical nerve stimulation, TENS. For screening, after the initial screening, all diabetics should be screened annually by examining sensory function in the feet and assessing ankle reflexes. Next, diabetic gastroparesis. Decreased GI motility and delayed gastric emptying due to decreased ability of the gut to sense the stretch of the bowel walls in the absence of a mechanical obstruction. Pathophysiology, impaired neural control of the gastric function, diabetic neuropathy. Decreasing ability of the intestines to sense the stretch of the bowel walls. So normally the stretch is the main stimulant for gastric motility. Clinical manifestations of diabetic gastroparesis: nausea, vomiting, bloating, early satiety, upper abdominal discomfort, and constipation in the setting of long-standing diabetes. On physical exam, may have epigastric distension or tenderness with a succussion splash, but no rigidity or guarding. For diagnosis, upper endoscopy is usually performed initially to rule out other causes, and a nuclear gastric emptying scintigraphy, delayed gastric emptying in the absence of a structural obstruction. Management: improved glycemic control and dietary modification is the initial management. Small, frequent meals with soluble fiber and low in fat. Prokinetics like metoclopramide or erythromycin or domperidone, they increase GI motility. Avoid medications that delay gastric emptying, like GLP-1 agonists, exenatide, and DPP-4 inhibitors as well. Diabetic nephropathy. Diabetes is the most common cause of end-stage renal disease as well. Pathophysiology: progressive kidney deterioration leading to microalbuminuria, which is the first sign of diabetic nephropathy. For diagnosis, on urine dipstick, you'll have a positive dipstick for proteinuria, 24-hour urine protein loss between 30 and 300 milligrams, a 24-hour urine for albuminuria, and they may have anemia and acidosis. For histology, importantly, you have the Kimmel-style Wilson lesions. These are nodule glomerular sclerosis, pink hyaline material around the glomerular capillaries from protein leakage. This is pathognomonic for diabetic nephropathy. So that's the Kimmel-Steele-Wilson lesions with pink hyaline material. It's pathognomonic for diabetic nephropathy. Management: ACE inhibitors or ARBs reduce protein leakage and slows progression via the afferent arterial dilation. Low sodium diet and strict glucose control. Screening is yearly for microalbuminuria, BUN, and creatinine. Next to SIADH, syndrome of inappropriate ADH. This is a non-physiologic excess ADH from the pituitary gland or ectopic source, leading to free water retention and hyponatremia due to the kidney's inability to dilute the urine and excrete the excess water. Etiologies: CNS, most common, subarachnoid hemorrhage, stroke, head trauma, meningitis, CNS tumors, post-op, or hydrocephalus. Pulmonary is possible, with small cell lung cancer, which produces an ectopic ADH. Also infection, like Legionella pneumonia and HIV. So remember, Legionella pneumonia and that hyponatremia, which would result from SIADH as we hold on to much more water, diluting the sodium. Medications: anticonvulsants, like carbamazepine, also hydrochlorothiazide, NSAIDs, chlorpropamide, remember that's a first-gen sulfonylurea, antidepressants, TCAs, SSRIs, also high-dose IV cyclophosphamide, and also ecstasy, MDMA, and narcotics. Others could be HIV, endocrine, such as hypothyroidism and Cone syndrome, which is primary hyperaldosteronism. Clinical manifestations: neurologic symptoms of hyponatremia and cerebral edema, confusion, lethargy, disorientation, seizures, or coma if severe. Diagnosis is by dilutional labs: normovolemic, hypotonic, hyponatremia, usually no signs of edema here. Decreased serum osmolarity, hypouricemia, and decreased BUN. For SIADH, you also have an increased urine osmolarity, a concentrated urine due to all the water being reabsorbed, and a urine sodium over 20 milliequivalents per liter. You'll have increased ADH levels, and diagnosis is made in the absence of renal, adrenal, pituitary, thyroid, or diuretic use. For management, you want to treat the underlying cause. Rapid correction of over 0.5 milliequivalents per liter per hour may lead to central pontine myelinolysis or osmotic demyelination. So if you're treating initially, you're going to pull all the water out of the CNS, which will lead to that. Mild, you want to do water restriction. Moderate to severe, ADH receptor antagonists like conivaptan and tolvaptan. And if it's severe hyponatremia, where the patient is obtunded, coma, or seizure, you do IV hypertonic saline plus furosemide. For chronic, you can do dimeclocycline, which inhibits ADH. So it basically causes a nephrogenic DI. Next, DI, diabetes insipidus. This is inability of the kidney to concentrate urine, leading to production of large amounts of dilute urine. Central DI, no production of ADH, whereas nephrogenic DI is renal insensitivity to ADH, and ADH is still being produced. So again, two types: central DI, no production of ADH, which is the most common type. Idiopathic is most common, destruction of the posterior pituitary, head trauma, CNS tumor, infection, or sarcoid granuloma. Nephrogenic is different. It's partial or complete renal insensitivity to ADH. Medications such as lithium, amphotericin B, dimeclocycline, as we just stated, is a treatment for SIADH refractory to more conservative management. Hypokalemia or hypercalcemia, which disrupts the kidney's concentrating ability. Acute tubular necrosis, and hyperparathyroidism. Clinical manifestations of DI, which will be polyuria, up to 20 liters per day, and polydipsia, excessive thirst to maintain water balance, high volume nocturia, and neurologic symptoms of hypernatremia, confusion, lethargy, disorientation, seizures, or coma, can occur when water intake is less than urinary water loss. Physical examination, dehydration, hypotension, and rapid vascular collapse in severe cases. For diagnosis, you'll see on labs an increased serum osmolality, increased urine osmolality, or rather a decreased urine osmolality and specific gravity, and an increased urine volume. So the urine is extremely dilute, and the serum is extremely thick, as we're just getting rid of all the water. Hypernatremia, if severe, due to the lack of dilution of the blood. Fluid deprivation test can be done for diagnosis, which establishes the diagnosis of DI. The normal response is progressive urine concentration. However, in DI, continued production of large amounts of dilute urine will occur, leading to a low urine osmolality because it's so dilute. Desmopressin ADH stimulation test, which helps distinguish central from nephrogenic DI. So in central DI, there'll be a reduction in urine output when you give DDAVP, which is desmopressin, and an increased urine osmolality as it does respond to ADH. Remember, in central, it's just the posterior pituitary's problem of not making the ADH. It's still responsive in the kidneys. So the DDAVP or desmopressin stimulation test will result in a change. However, in nephrogenic, the stimulation test they'll still have continued production of large amounts of dilute urine, so they won't even respond to the ADH at all. Since it's the kidneys that, no matter how much ADH we have in the body, it's the kidneys that can't accept it. So how do we manage central diabetes insipidus? This is DDAVP, intranasal injection or oral. Carbamazepine is second line, or chlorpropamide. Management of nephrogenic is going to be correct the underlying cause, sodium and protein restriction, as well as HCTZ, indomethacin, or miloride if symptoms persist. A miloride for lithium-induced, importantly. So if it's lithium-induced, it's nephrogenic, and you use a miloride to treat it. Next, we'll move into calcium disorders. So a few things about calcium. 99% of calcium is in the bone, and 1% is in the extracellular fluid. 50% of extracellular fluid calcium is ionized into its active form. It's bound to albumin. Normal calcium levels are 8.5 to 10, and vitamin D is required for intestinal calcium absorption. Calcium is important to bone, blood clotting, normal cellular function, and neuromuscular transmission. Calcium is maintained within a normal range via 3 hormones. Hypocalcemia stimulates increased parathyroid hormone and increased calcitriol, vitamin D, secretion. Increases blood calcium via increased GI and kidney calcium reabsorption and increased bone calcium reabsorption via increased osteoclast activity, breaking down the bone, leading to phosphate and calcium to become more in the serum. Parathyroid hormone also inhibits phosphate reabsorption, so the phosphate is usually in the opposite direction of the PTH levels in primary parathyroid disorders. So increase in parathyroid, we're actually going to decrease the phosphate by excreting more of it through the kidneys. And hypercalcemia stimulates increased calcitonin to tone down the calcium and decreases blood calcium, decreasing calcium and GI and kidney reabsorption, and increased bone mineralization. So it increased the osteoblasts, which are building up more of the bone, taking that calcium from the serum. Moving to hypercalcemia. Etiologies of hypercalcemia are 90% due to primary hyperparathyroidism or malignancy. Primary hyperparathyroidism is the most common cause overall. A parathyroid adenoma, MEN, multiple endocrine neoplasia, or lithium therapy. Malignancy due to PTH-related protein production. So if you see PTH-related protein production, that's indicative of malignancy. Also, thiazide diuretics can cause hypercalcemia. So remember, they increase GLUC, glucose, lipids, uric acid, and calcium. Also, hyperthyroidism, inadvertently increasing the thyroid, inadvertently increases the PTH as well, since they're anatomically near each other. Vitamin D or vitamin A intoxication, and granulomas like sarcoidosis. Clinical manifestations of hypercalcemia. Most are asymptomatic, but you have the classic stones, bones, abdominal groans, and psychiatric moans. So stones, nephrolithiasis, due to calcium oxalate and phosphate. Bones, bone pain and fractures. Abdominal groans, ileus and constipation importantly. Decreased DTR and weakness. Hypercalcemia decreases muscle contractions. Psychic moans, depression, anxiety, cognitive dysfunction, and increased vascular tone, hypertension. So also a shortened QT is important to know. Diagnosis, the first step is to repeat the measurement to verify in asymptomatic patients and correct the calcium for albumin. As we said, half of calcium in the serum is bound to albumin. Ionized serum calcium is more accurate than total serum calcium, since you might have a change in albumin. And intact PTH. Once hypercalcemia is confirmed, you want to rule out primary hyperparathyroidism by getting an intact PTH. Also, like we said, PTH-related protein, often ordered if intact PTH is normal or low to rule out malignancy. Also, you want to get a 1-5 vitamin D level and 24-hour urinary calcium. Calcium excretion is usually elevated or normal high in hyperparathyroidism and malignancy. You always want to get an EKG, looking for a shortened QT, prolonged PR, and QRS widening. So the management of mild hypercalcemia, which is under 12 milligrams per deciliter, no immediate treatment is needed. Treat the underlying cause and increase water intake, which promotes calcium excretion, and will also help prevent the calcium stones from forming. Management of moderate, 12 to 14. IV fluid is the initial management of choice if associated with significant symptoms, promotes excretion and dilutes it. IV loop diuretics like furosemide can be added to promote calcium excretion, not HCTZ, importantly. Calcitonin may be helpful in an adjunct to malignancy. faster onset of action compared to bisphosphonates. You can use bisphosphonates. Zoledronic acid and pemendronate can be given with calcitonin in malignancy. Calcitonin tones down the calcium. Denosumab may be adjunctive in malignancy-related hypercalcemia. And glucocorticoids in granulomatous states decrease the inflammation. Next, hypocalcemia. Etiologies of hypocalcemia are hypoparathyroidism as the most common overall cause. Also autoimmune destruction or removal of the parathyroid gland during neck surgery. Thyroid surgery as well. Chronic renal disease or liver disease. If PTH is increased, you want to look at a secondary hyperparathyroidism, increased PTH response to hypocalcemia, the wasting of the calcium. Vitamin D deficiency, osteomalacia and rickets, we can't absorb the calcium. Hypomagnesemia, hyperphosphatemia, and hypoalbuminemia, which would decrease the total calcium being able to be carried. So magnesium, parathyroid, hypoalbuminemia. Medications, diuretics can cause it. Only loop diuretics, however. HCTZ would increase it. Calcium chelators, like high citrate during blood transfusion, bisphosphonates, and denosumab. So remember, interestingly, calcium chelators, high citrate during blood transfusion. So if there's citrate in the blood transfusion, you have to be worried about a hypocalcemia as it's binding all the calcium and taking it away. Clinical manifestations. Most are asymptomatic. For hypocalcemia, increased muscle contractions. Because hypocalcemia decreases excitation threshold, increasing muscle and nerve excitability occurs. So you'll have muscle cramps, bronchospasms, finger or circumoral paresthesias, and tetany. Importantly, the Chvostek's sign, which is a facial spasm with tapping of the facial nerve, and also Trousseau's sign, which is inflation of the blood pressure cuff above systolic, causes a carpal spasm. Also increased DTRs and seizures. So it's important to know it causes these contractions due to the lack of the positive charge in the serum. So the resting threshold will be more negative, and they're more likely already to generate an impulse. Cardiovascular, CHF, and arrhythmias. Dry skin, psoriasis. GI, diarrhea, abdominal pains or cramps. Skeletal, abdominal distension, osteomalacia, osteodystrophy. For diagnosis, decreased free ionized calcium is more accurate than total serum calcium. Order intact PTH, not PTH protein related, which would indicate cancer. Magnesium to see if it's hypo, phosphate to see if it's hyper, BUN and creatinine to see if there's renal failure, and vitamin D metabolites to see if they're low. Albumin levels may be needed to correct calcium for hypoalbuminemia. So to correct the calcium, it's 0.8 times the normal albumin, which is 4.4, minus the patient's albumin, plus the serum calcium. The EKG will show a prolonged QTV interval, which is classic. And management of hypocalcemia, you want to give oral calcium and vitamin D if it's mild. Potassium and magnesium repletion may be needed. If it's severe or symptomatic, IV calcium gluconate or IV calcium carbonate as well to stabilize the cardiac membrane. Next, we'll go into parathyroid. So first, primary hyperparathyroid. This is excess parathyroid hormone via the chief cells of the parathyroid. And remember, the parafollicular cells of the thyroid stimulate increased, that would be calcitonin rather. So etiologies, parathyroid adenoma is the most common cause, 80 to 85%, and also parathyroid hyperplasia or enlargement are causes. Lithium is an important cause of primary hyperparathyroidism, which increases the calcium, and MEN1 and MEN2A. Malignancy is rare. So remember, MEN1 is hyperparathyroidism, pituitary and pancreatic tumors, and MEN2A is, again, hyperparathyroidism, pheochromocytoma, and medullary thyroid carcinoma. Clinical manifestations, most are asymptomatic. They may have signs of hypercalcemia, again, the stones, bones, abdominal groans, and psychiatric moans, nephrolithiasis, painful bones, fracture, ileus, constipation, nausea, vomiting, weakness, decreased deep tendon reflexes. A diagnosis can be made by hypercalcemia plus an increased intact PTH, that's intact PTH, and decreased phosphate, increased 24-hour urine calcium excretion, and an increased vitamin D. Also ancillary may have osteopenia on bone scan, imaging studies to detect parathyroid adenoma, ultrasound or nuclear scanning. Management is parathyroidectomy as definitive, vitamin D and calcium supplementation post-parathyroidectomy to prevent hypocalcemia. Cinacalcet inhibits the release of PTH in patients that are not surgical candidates. So cinacalcet is a calcium receptor stimulator, so it makes the parathyroid think that there's more calcium in the blood than there actually is by increasing the sensitivity of the receptors. So that's why it can be helpful in hyperparathyroidism. May be observed in mild cases. In management of severe hypercalcemia, you want to do IV fluids, and they may need furosemide added if severe. Next, the opposite, hypoparathyroidism. The two most common etiologies are post-neck surgery, like a thyroidectomy or parathyroidectomy, or autoimmune destruction of the parathyroid gland. Radiation therapy, hypomagnesemia, importantly, congenital pseudo-hypoparathyroidism, and DeGeorge syndrome, parathyroid hypoplasia. Clinical manifestations, signs of hypocalcemia, increased muscle contraction, carpopedal spasm, perioral numbness, tetany, Trousseau sign, again, carpopedal spasms when the blood pressure cuff is inflated, and Chvostek sign. Tapping on the cheek causes facial spasm, also mental irritability and increased deep tendon reflexes for this hypoparathyroidism. Diagnosis will be a triad of hypocalcemia, decreased intact PTH, and increased phosphate. EKG will show a prolonged QT, which increases the risk of arrhythmias. And for management, you want to do calcium supplementation plus activated vitamin D, calcitriol. Acute symptomatic hypocalcemia, IV gluconate. And remember, calcitriol has 3 in it, so it's a third step in vitamin D synthesis, the final step. Next, we'll move to anterior pituitary tumors. Anterior pituitary tumors, for prolactinoma, this is a benign tumor, adenoma, of the lactotroph cells, most common type of pituitary adenoma. Prolactin functions. Prolactin is responsible for lactation, suppression of pregnancy during lactation, and suppression of gonadotropin-releasing hormone, leading to increased FSH and LH. Dopamine inhibits prolactin release. Thus, increasing the dopamine in antipsychotics has the side effect of increasing prolactin, like in the first-gen antipsychotics. Manifestations in women of prolactinoma due to hypogonadism, oligomenorrhea, amenorrhea, and infertility. Galactorrhea, although this is rare. Local compression, importantly, headache and visual changes. Manifestations in men, hypogonadism, erectile dysfunction, decreased libido and infertility, and rarely gynecomastia. Local compression can cause headache or visual changes as it presses on the optic chiasm. Physical examination, pituitary tumors can compress the optic chiasm again, leading to bitemporal hemianopsia. Diagnosis, endocrine studies, increased prolactin, decreased FSH and LH. TSH, growth hormone, and ACTH levels are ordered because prolactinomas can cause hypersecretion or hyposecretion of other hormones of especially the anterior pituitary. MRI is the study of choice to look for cellular lesions in the sella turcica in pituitary tumors. Small adenomas may not be visible. For management of prolactinoma, dopamine agonists, as dopamine inhibits prolactin, such as cabergoline or bromocriptine, are the first-line treatment for both symptomatic macro and microadenomas. Cabergoline is better tolerated. Watchful waiting may be employed if asymptomatic, and transsphenoidal surgery is usually reserved for prolactinomas refractory to medical management or large adenomas over 3 centimeters in women who wish to become pregnant. Radiation therapy is rarely used. Now somatotroph adenoma. This is a growth hormone secreting pituitary adenoma that leads to acromegaly in adults or gigantism in children if it occurs before the epiphyseal closure. Pathophysiology. Growth hormone is a counter-regulatory hormone that increases glucose. Increasing growth hormone stimulates the increased hepatic production of IGF, insulin-like growth factor. Clinical manifestations of somatotroph adenoma, or a growth hormone secreting pituitary adenoma, are diabetes mellitus from glucose intolerance, enlargement of soft tissues, cartilage, and bone, hands, feet, skull, tongue, forehead, and jaw. Jaw is macroganthia, increased ring, shoe, and hat size. They can have carpal tunnel due to compression, obstructive sleep apnea, increased space between the teeth, and coarse facial features. Headache is very common. Visual symptoms like bitemporal hemianopsia, deepening voice, thickening skin, skin tags, weight gain, and arthralgias. Hypertension, kidney stones, and colonic polyps. Diagnosis is by IGF as the initial screening choice, insulin-like growth factor. Confirmatory is oral glucose suppression test, increased growth hormone levels seen in acromegaly. Normal response is growth hormone suppression. So here the growth hormone just doesn't stop, and you can know that it might be an adenoma. MRI imaging is the test of choice to evaluate for cellular or pituitary lesions after laboratory confirmation. So you want to do a screening with IGF-1, then you do secondary, you do an oral glucose suppression test, and then finally MRI. Management is a transsphenoidal surgery, is a management of choice for removal of active or compressive tumors. You can also do medical. The indications are adjunct to surgery or when surgery is not possible. So this is opposite of prolactinoma, where you want to do the cabergoline, which is medical management before surgery. But for growth hormone secreting pituitary adenoma, somatotroph, you want to do the surgery, transsphenoidal resection, before you do medications like octreotide or lanreotide. And octreotide and lanreotide are somatostatin analogs that inhibit growth hormone release. Radiation therapy is reserved for cases not responsive to surgical or medical management. Next, corticotroph adenoma. This is an ACTH-secreting pituitary adenoma that leads to hypercortisolism, Cushing syndrome, also known as Cushing's disease especially, as the disease is pituitary. Clinical manifestations: proximal muscle weakness, weight gain, headache, oligomenorrhea, polyuria, osteoporosis, and mental dysfunction. Differentiating tests, importantly, the presence of an increased baseline ACTH and suppression of cortisol on high dose dexamethasone suppression distinguishes Cushing's disease from other causes of Cushing's syndrome, hypercortisolism. MRI of the pituitary imaging is the test of choice, and sampling of the petrosal sinus if MRI is negative, as the MRI may miss small tumors. Management is transsphenoidal resection as the treatment of choice. No drugs in corticotroph adenoma or Cushing's disease itself. And again, Cushing's disease, increased baseline ACTH, and suppression of cortisol on high dose dexamethasone suppression test. Anterior hypopituitarism. Pituitary destruction or deficient hypothalamic pituitary stimulation, congenital or acquired, could be tumor, infiltrative disease, or bleeding into the pituitary, such as in Sheehan syndrome, which is a postpartum infarct from blood loss during pregnancy. Pituitary infarct, radiation therapy. Can be a combination of growth hormone deficiency for manifestations like dwarfism, metabolic derangements in adults, hypothyroidism, and gonadotropin deficiency. For a diagnosis of anterior hypopituitarism, both the target hormones and the pituitary hormones are decreased in the same direction. So secondary pituitary problem or tertiary hypothalamic problem. TSH and free T4 are both decreased if secondary hypothyroidism, and ACTH and cortisol are both decreased if secondary hypocortisolism. Management: hormone replacement therapy for all these hormones from the anterior pituitary. Next will be growth hormone deficiency. Deficiency in the pituitary production of growth hormone. Etiologies can be congenital or acquired, tumor, infiltrative disease, again bleeding into the pituitary, which is Sheehan syndrome, pituitary infarct or radiation therapy, children or infancy, short stature, growth delays, dwarfism, fasting hypoglycemia. In adults, mild to moderate central obesity, increased blood pressure, dyslipidemia, importantly, decreased bone mass in men, decreased cardiac output, muscle wasting, increased inflammatory markers, and impaired concentration for growth hormone deficiency. Diagnosis is by arginine and sleep stimulation test. No change in growth hormone if from the hypopituitarism. Measurements of basal growth hormone level do not distinguish between normal and subnormal growth hormone secretion. So, do not do a basal measurement of growth hormone in growth hormone deficiency. Hyperprolactinemia. The etiologies of hyperprolactinemia are a prolactinoma as the most common cause, also a hypothyroidism. Increased thyroid releasing hormone stimulates prolactin, also acromegaly, cirrhosis, and renal failure. Pharmacologic, dopamine antagonists, first and second generation antipsychotics, such as risperidone, haloperidol, metoclopramide also, promethazine, and prochlorperazine, because dopamine is an inhibitor of prolactin, SSRIs, TCAs, cimetidine, verapamil, and estrogen. Physiologic, pregnancy, stress, and exercise. Pathophysiology of hyperprolactinemia. Prolactin inhibits gonadotropin releasing hormone, leading to hypogonadism. Manifestations in women, hypogonadism, oligomenorrhea, amenorrhea, infertility, and vaginal dryness, also rare galactorrhea. Manifestations in men, hypogonadism again, erectile dysfunction, decreased libido, infertility, and rarely gynecomastia. Workup will be a serum prolactin, TSH, importantly, beta HCG, BUN, creatinine, and LFTs. So for TSH, we should see a decrease in T3, T4 prior as it's a result of negative feedback. Management, it depends on the cause. Medication-induced hyperprolactinemia, discontinue the offending agents, and dopamine agonists can be used, again, like cabergoline and bromocriptine, that inhibit prolactin. And surgical or radiation therapy may be needed in some cases of refractory prolactinomas. Hypogonadism is next. Decrease in either or both of the primary functions of the testes, testosterone and sperm production. Primary hypergonadotropic hypogonadism is a decrease in function of the Leydig cells. So the Leydig cells produce testosterone, so this will be a decreased testosterone synthesis. Seminiferous tubule dysfunction, also alcoholic liver disease. Secondary hypogonadism is a hypogonadotropic hypogonadism. This is a disorder of the pituitary gland or the hypothalamus, such as pituitary adenoma, craniopharyngioma. Affects both spermatogenesis and Leydig function. Clinical manifestations: adolescence, failure to undergo complete puberty, decreased secondary male characteristics. Also for adults, decreased libido, energy, body hair, muscle mass, osteoporosis, gynecomastia, infertility. Diagnosis will be a morning serum total testosterone, which will be decreased. If subnormal, testosterone levels should be repeated along with FSH and LH to distinguish primary from secondary. Primary will have decreased testosterone plus a normal FSH if limited to the Leydig cells, or a high FSH, which will be a seminiferous tubule dysfunction, as the FSH is still working, it's just the tubules that are not. For secondary, there'll be again a decreased testosterone, plus a decreased FSH and LH in the same direction, or normal FSH. Sex hormone binding globulin, semen analysis if hypogonadism is part of a fertility workup. Management, testosterone replacement therapy if testosterone deficiency seen on 3 separate occasions. Infertility, in vitro fertilization of sperm extracted from the testes if primary. Gonadotropin therapy or pulsatile gonadotropin releasing hormone if pituitary function is normal for management. Next will be metabolic syndrome, also known as syndrome X, insulin resistance syndrome. Syndromes of metabolic abnormalities that increase the risk of complications such as diabetes and cardiovascular disease, also known as Syndrome X or insulin resistance syndrome. Pathophys, insulin resistance is the key component. Free fatty acids are released, which causes an increase in triglycerides and glucose production, as well as reduction in insulin sensitivity, leading to insulin resistance and hyperinsulinemia. High levels of insulin cause sodium reabsorption, leading to hypertension. So the diagnosis is important for this, and you need 3 of the following 5 criteria, 3 of 5. A decreased HDL, so under 40 in men and under 50 in women. An increased blood pressure, over 135 systolic or over 85 diastolic, or they're on drugs to treat hypertension. A fasting triglyceride level over 150, or they're being treated for hypertriglyceridemia. A fasting blood sugar over 100, or being treated for diabetes already. An increase in abdominal obesity, waist circumference over 40 inches in men and 35 inches in women. So you need 3 of 5 of those. Low HDL, increased blood pressure, increased fasting triglycerides, increased blood sugar, and increased abdominal obesity. 3 of 5. Management is lifestyle, weight reduction, exercise, and increased physical activity. Diet rich in fruits, veggies, and weight loss. Weight loss medications. Phentermine, 3 months, short-term use only. This is a sympathomimetic with unknown mechanism of action, similar to amphetamine. Phentermine, or topiramate, no restriction on treatment duration. Adverse effects are insomnia, constipation, palpitations, headaches, and paresthesia. Lorcaserin, selective serotonin agonist, 5-HT2C receptor that induces satiety. Lorcaserin. Think about casein for lorcaserin. Casein is a protein and is an animal protein that slows digestion. So sounds like casein induces satiety. Lorcaserin. Orlistat inhibits fat absorption. I think of oily orlistat. So phentermine, sympathomimetic, and topiramate. Phentermine, also similar to amphetamine. Lorcaserin, casein, slows, induces satiety, and orlistat inhibits fat absorption itself. Bariatric surgery may be used in some patients. Next, to go into the syndromes of multiple endocrine neoplasia. So first, starting off with men 1, this is a rare inherited disorder of 1 or more overactive endocrine glands. These are the 3 Ps: parathyroid, pancreas, and pituitary, also known as Wermer's syndrome, associated with menin gene defect. Most tumors are benign, especially before 30. And again, the clinical manifestations are due to the tumor that they are. So parathyroid, hyperparathyroidism is most common. Pancreatic tumors are the second most. And pancreatic can be Zollinger-Ellison syndrome, which is the gastronoma, insulinomas, glucagonomas, somatostatinomas. Those are pancreatic. And also prolactinomas. Other tumors include carcinoid, non-functioning, polypeptide, malignant, and lipomas. So the 3 Ps: parathyroid, pancreas, and pituitary for men 1. Management is tumor specific, and screening is PTH for parathyroid, calcium, gastrin, and prolactin. MEN2, multiple endocrine neoplasia 2. This is a rare inherited disorder of 1 or more overactive endocrine glands due to the RET proto-oncogene. So MEN2A, which is 90%, encompasses medullary thyroid carcinoma, pheochromocytoma, and hyperparathyroidism. MEN2B, which is only 5%, is again medullary thyroid carcinoma, pheochromocytoma, but not hyperparathyroidism. Instead, it's neuromas or Marfanoid syndrome. And then you have familial MTC, which is medullary thyroid carcinoma. So MEN2B, again, medullary thyroid carcinoma, pheochromocytoma, neuromas, and Marfanoid habitus. That's MEN2B. MEN2B is associated with more aggressive form of medullary thyroid carcinoma, may present in infancy. Mucosal neuromas of the lips, tongue, eyes, conjunctiva, nasal, and laryngeal mucosa, and a Marfanoid habitus, including high-arched palate, pectus excavatum, and scoliosis. Diagnosis will be genetic testing and imaging for tumors. Screening in patients with MEN2, calcitonin for the medullary thyroid carcinoma, epinephrine, importantly for the Pheo, PTH for the hyperparathyroidism, and calcium as well. And that will complete our endocrine system of Pance Prep Pearls.